Respected Professor Sir and my dear students, I welcome you all to this ISA online DNB academic activities today. Today we have a theory question discussion on CRPS followed by a C8 and case presentation by Dr. Jayabharati from RH Perambur. Over to Professor and students. Thank you.
So we finish the discussion. Yeah.
Yes, sir.
Okay.
Good evening, sir. My topic is on CRPS, that is a complex regional pain syndrome. CRPS is a clinical disorder characterized by severe continuous pain in the affected extremity disproportionate to the inciting event. It is often accompanied by sensory, vasomotor, pseudomotor, and motor or traffic changes. The pain is regionally restricted and is not related to a specific dermatome. CRPS usually occurs after trivial injury but can occur even in the absence of an injury. There are two types of CRPS, that is type 1 and type 2. Type 1 CRPS, also known as reflex sympathetic dystrophy, in which there is no demonstrable nerve lesion, that is, there is no evidence of major nerve damage. Type 2 CRPS, also known as causalgia, has demonstrable nerve lesion, that is, evidence of nerve damage is seen. In etiology, women are affected more than men, with the highest incidence seen in 61 to 70 years of age. Most common cause of CRPS is seen following fractures. Upper extremity is affected more than lower extremities. CRPS can also occur following post-surgical condition, contusions, or sprain. It can also occur following cerebrovascular accidents, spinal cord injuries, or cardiac ischemia. Pathophysiology of CRPS, it is usually multifactorial, including inflammatory changes, immunological changes, autonomic changes, and central and peripheral sensitization. In CRPS, classical signs of inflammation such as pain, redness, swelling, rise in temperature is seen. Increased level of pro-inflammatory markers such as interleukin-6, 8, human necrosis factor alpha in the blister fluid of affected limb suggests this local inflammatory response. In case of peripheral sensitization, pro-inflammatory cytokines suggested to be involved in peripheral nociceptor activation and sensitization, which causes symptoms such as pain or allodynia. Increased level of calcitonin gene-related peptide and substance B causes neurogenic dilatation of arterioles and plasma protein extravasation, leading to edema or sweating. In central sensitization, continuous peripheral activation after injury increases the synaptic nociceptive firing in dorsal horn, which decreases the threshold of response to mechanical and thermal stimuli, causing the symptoms of allodynia and hyperpathia. Glutamate and substance B are found to be the main mediators of central sensitization. In cortical reorganization, structural changes in motor cortex area and sensory homunculus resulting in smaller representation of affected limb than unaffected limb results in patients having altered perception and movement of affected limb. In case of autonomic changes, there is a dysregulation of adrenergic and nociceptive receptors. Increase in alpha-1 adrenergic receptors and decreasing circulating norepinephrine causes the changes in temperature and color of the affected limb. In case of ischemia reperfusion injury, deep tissue hypoxia and reperfusion injury causes free radicals and cytokine release, resulting in endothelial damage and again nociceptor excitation. In case of immunological changes, cytokine production is partially driven by innate immunity, which potentiate peripheral sensitization to noxious stimuli. It is believed that in CRPS, there might be autoantibodies formed against autonomic nervous system, potentiating the inflammation and exacerbating the symptoms. In case of psychological stress, patients with a post-traumatic stress disorder, anxiety, depression have reported with increased incidence of CRPS. This could be explained by stress-induced increase in systemic catecholamine release. Clinical presentation of CRPS. Patient present with severe constant pain disproportionate to the initial injury. Pain is usually described as stabbing, penetrating, throbbing, or burning in nature. There also is difference in skin temperature is seen, sweating pattern, color change, swelling, or changes in nail or hair growth can be seen on the affected limb compared to the healthy limb. Diagnosis is usually clinical, which is based on the modified IASP diagnostic criteria, that is Budapest criteria, which includes the following criteria. The first one is continuing pain disproportionate to the exciting event. Second, at least one symptom in each category of sensory, vasomotor, pseudomotor, and motor trophic changes. Sensory symptoms include hyperesthesia and allodynia. Vasomotor symptoms include temperature asymmetry, skin color changes, or skin color asymmetry in the affected region. Pseudomotor changes include edema or sweating changes in the affected limb. Motor changes include decreased range of motion, motor dysfunction like weakness, tremors, dystonia, or trophic changes like hair, nails, skin in the affected limb. Third is at least one sign in two or more categories. That is, the category includes sensory, again sensory, vasomotor, pseudomotor, and motor. In case of sensory, there is evidence of hyperalgesia to pinprick or allodynia to light touch or deep somatic pressure or joint movement. In vasomotor, there is evidence of temperature asymmetry, skin color changes, or asymmetry. Pseudomotor includes evidence of edema or sweating changes. Motor or trophic evidence includes decreased range of motion and motor dysfunction and trophic changes in hair, skin, and nail. Fourth one is no other diagnosis better explains the signs and symptoms. Additional tests includes X-ray, which is used to detect osteopenia and patchy osteoporosis as early as 2 weeks. Three-phase bone scan, which is used to detect early bone changes than the X-ray. Sweat test can also be used, where sweating is measured at basal level and cholinergic stimulation on the affected limb. Difference in the output is measured. Prevention of CRPS. Studies have shown that after the injury or surgery, vitamin C 500 milligram per day for 50 to 60 days decreases the risk of developing CRPS. Management of CRPS involves multidisciplinary approach. The treatment includes 4 Ps, that is patient education, physical therapy, pharmacological therapy, and psychological therapy. Patient education. We have to make the patient understand that CRPS is not hereditary and it usually precedes injury, but can also occur without any significant injury. It can also persist well after the completion of healing process, and there is no specific cure. We should explain that multidisciplinary approach in treatment can reduce the severity of the disease process. Physical therapy aims to increase the range of motion and functionality of limb and reduces the pain. Commonly used physical therapies are gradual weight bearing, fine motor exercises, isotonic strengthening, and aerobic conditioning. Early involvement of specialist physiotherapists and occupational physiotherapists shown to be beneficial. Pharmacological therapy involves analgesics, where gabapentin and tricyclic antidepressants helps with treating the nociceptive pain in CRPS. Anti-inflammatory drugs like NSAIDs, corticosteroids, bisphosphonates helps in reducing inflammation by decreasing the mediators of inflammation. Bisphosphonates also helps with decreasing the bone resorption, which helps in improvement with pain and mobility. For sympathetically mediated pain in CRPS, alpha-2 agonists like phenoxybenzamine and clonidine is used. Antispasmodics like intrathecal baclofen helps in dystonia. NMDA antagonists like ketamine helps with allodynia and hyperalgesia. Sympathetic procedures like stellate ganglion blocks, lumbar sympathetic blocks have shown minimal benefit. Radio frequency neurolysis helps to decrease the incidence of neuritis. Other non-pharmacological treatment like acupuncture and spinal cord stimulation showed minimal benefit. Psychological treatment, cognitive behavioral therapy is found to be useful in CRPS. Underlying psychiatric condition like post-traumatic stress disorder, anxiety, depression should be actively identified and counseled. That's all.
Excellent. Very good. Very nicely prepared and presented. But today only it struck me that you are all preparing nicely all the points and then reading out from the notes that you have prepared. What I thought while I was browsing and seeing, I thought you should try to take it in your mind and try to present it without looking at the notes, so that exam you are not going to see it from the notes and write. So you are going to write it from your memory only. So what I thought, as a practice, all of you prepare the notes and then read it again and again, keep it all the points in your mind and try to describe everything in the class without seeing the notes. Then you can lastly refer and see whether you have missed out any points instead of verbatim reading from the notes. You may tend to forget. So I thought if you prepare that way and try to read, express it without looking at the written notes, I think it will stay in your mind much more strongly and you will be able to reproduce it in the examination. Okay, that's a very nice presentation that you have made.
Yes, sir.
But again, as I said, sorry, you have to time your answers and then try to prepare it and make sure that you will be able to write all these points in the exam within the given time. That has been the focus I have been telling you again and again. So try to keep a stopwatch and try to write all the answers after you
Yes,
prepare it and time it and see whether you can finish it within the given time. Usually CRPS is given only as a short note question. Okay, so
yes,
for
sir.
that they expect only the main points to be written. So did you describe what type of pain it is? CRPS, under what category of pain it comes?
Neuropathic pain, sir.
The neuropathic pain. And second thing, it is
Yes,
a chronic pain. Sometimes,
yes,
the complex regional pain syndrome can also be worded as chronic regional pain syndrome.
chronic pain.
So both mean the same. And the two categories, type 1 and type 2. Type 1 was earlier called as reflex sympathetic dystrophy, and type 2 was called as causalgia because there was a cause. There was actually a nerve damage was there. So it was called causalgia. So easy to remember because there was a cause, it was called causalgia. And all the features have been there. And with regard to the pseudomotor changes, one small correction I would like to make this in the acute phase, there is edema and redness. But later on, when the pain becomes very chronic, the limb turns blue because instead of the vasodilatation, the limb goes into
Vasoconstriction.
vasodilatation and it turns blue. Okay, so that one point I think you can change a little bit.
Yes, sir.
Otherwise,
Yes, sir.
it was a fantastic presentation. Anyway, I will just show my PPT also for those